Okay, welcome everyone. My name is Rob Lehman. I'm one of the members of the Cataract and Primary Eye Care Service. Today we're going to talk about the pre- and post-op evaluation of the cataract patient. Now, before you get to the operating room and start operating, you have to make sure the patient is an appropriate patient to do cataract surgery on, and the decision to operate is based on multiple factors. First, you have to consider what is the personal status of the patient. In other words, are they living in a nursing home where their visual needs may not be that great, or are they a trucker trying to drive at night and experiencing issues with glare? What's the health status of the patient? Is the patient healthy enough to undergo cataract surgery? And what are the patient's visual needs? So you have to get to know the patient. Now, the most important thing I'm going to tell you this morning is the next thing, and that is the critical issue preoperatively is to make sure that the patient's expectations are appropriate for the potential outcomes. So what's that mean? Well, the patient says to you, my neighbor down the street just had cataract surgery and they're seeing 20/20 one day after the surgery without any glasses. And you're looking at the patient, you know they've got moderate macular degeneration, so you need to have a long discussion to make sure their expectations are appropriate for what you potentially can do for them. What questions do we ask patients who are potential cataract patients? Well, you want to ask, are they having difficulties with distance vision? Is the distance vision worse at night or in bright sunlight? In other words, are they having trouble with glare? Are they having trouble reading? Is the visual loss gradual, which is typical of cataracts, or rapid, which is pretty much not associated with cataract? However, in the rapid loss of vision, you have to dissect that a little further to make sure it's not sudden discovery, because sudden discovery certainly can be associated with cataracts. But a rapid loss of vision is something else. And you also want to ask for about a history of Flomax use, and we'll get into that a little bit later. Other questions. Is there a presence of a lazy eye? What was their vision like when they were in their 20s? Did they have muscle surgery? You want to really find out if they've had amblyopia, because obviously that's going to impact on their final outcome. Are these problems that they're having interfering with activities of daily living? And why is that important? Well, it's especially important because the insurance companies are going to be paying for this, and they want to make sure there's a good reason why the patient underwent cataract surgery, and you need to document that they're actually having a problem. You want to ask about a history of trauma, especially in a patient who has a monocular cataract. Let's talk about the different types of cataracts and the associated visual complaints. First, let's talk about nuclear sclerotic cataracts. These are patients that tend to have poorer distance vision than near. They tend to progress slowly. It's an older population. And these people have what's called a subjective-objective disconnect. So you sit there at the slit lamp and look at them and you go, wow, this looks like a really dense lens, and they're seeing 20/40 and not having any troubles. And these patients don't complain as bitterly, partly because it's such a slowly progressive onset. And here you can see a patient who has a pretty dense nuclear sclerotic cataract, and you could look at that and say, boy, that patient's really going to have trouble, and they could be seeing 20/40 and not having a lot of trouble and not being really symptomatic with it. However, a subset of people with nuclear sclerotic cataracts are patients who have clefts or vacuoles, and you can see them right here. What does that represent? Well, we normally think that the lens ages uniformly, but in fact it doesn't. And certain areas of the lens can age differently than other areas. And in this case, you have an area where it's aged differently, and now you have a different index of refraction in this area compared to the rest of the lens. And what that will do is two things. One is it can lead to monocular diplopia. So that is a not uncommon complaint in patients who have nuclear sclerotic cataracts with clefts. The other thing is that these clefts can sometimes act sort of like posterior subcapsular cataracts, where they can cause glare. Speaking of which, let's turn our attention to posterior subcapsular cataracts. These patients tend to have poorer reading vision than distance. Their decreased distance vision is noticeable, especially in sunlight or when they're trying to drive at night, secondary to headlight glare. They tend to be younger patients, and they tend to be much more symptomatic, partly because of the fact that this is very often rapid in onset. And here you can see a patient with a significant posterior subcapsular cataract taking up most of the visual axis. And what happens is the light comes in, hits this area, this opacity, and gets scattered, and that's the mechanism for their glare. Cortical cataracts are not as easily predictable based on the appearance, but you can sometimes get a hint based on what they look like. The symptoms oftentimes depend on the position of the opacity relative to the visual axis, and I'll show you in a second. And they oftentimes cause symptoms similar to but less symptomatic than posterior subcapsular cataracts. And here's a patient who has, in a dilated eye, has cortical spokes that are sort of encroaching into the visual axis. And if you think of that the pupil would come into here, you can see that there's still some cortical spokes in the visual axis, and that can cause some glare symptoms as well. Here's a patient with a white lens, a white cortical cataract, and these create a whole set of additional issues when you get to the operating room and have to be dealt with in a different way. But certainly a type of cortical cataract, and obviously this patient's vision is in the range of hand motions or light perception. Now, what other things can cataracts cause? Well, we already talked about monocular diplopia, but the other thing that can occur in patients who have especially nuclear sclerotic cataracts is they can develop progressive myopia. And if this is asymmetric, you can end up in a situation where you now have a big difference between one eye and the other eye, and that we call anisometropia. And if the patient has more than 3 to 4 diopters of anisometropia, they're probably going to have trouble correcting that with glasses. The reason being is that the eye that's more myopic minimizes the size of the image, and the patient develops what's called anisoconia, which means a difference in the image sizes between one eye and the other. And the patient won't come in saying, I can't take these glasses because I can't use them because the images are different sizes. They'll just say there's something wrong with these and I can't tolerate them. Other cataract considerations. Well, occasionally cataract surgery is necessary to improve the visibility of the posterior pole for diagnostic or treatment purposes. If somebody has a macular lesion such as macular degeneration that needs to be lasered, or they have diabetic retinopathy that needs to be lasered, those are reasons that if you can't see, the retina doc can't see well enough and can't treat them, then that patient may need to have cataract surgery to allow for the treatment. This is also a really important point, and that is that problems and issues discussed preoperatively are called expectations, and problems and issues that are discussed postoperatively in the patient's eyes are called complications. So you want to do as much of your discussing of things that you know are potentially coming down the pike preoperatively, so they're in the expectation category. How do we document visual function? Well, we typically use a Snellen acuity with the best correction. But the problem with that story is that we're sitting in a dark room looking at a high contrast target, and that's not really the way the real world is. So the patient can actually be functioning pretty well in our lanes, but then go out into the real world and not be doing nearly as well. And a lot of times it's because of glare, so we do have a way to test for that. One is called the contralight test, which essentially means you take a Snellen acuity chart and put it in a window that's backlit with sunlight. That's not often done, but what is often done is the brightness acuity test, which I'll show you in a second. We have one of those up in the clinic. And the other way, low-tech way to do this is to take a flashlight and shine it in from the side as the patient's trying to read the eye chart. The problem with this is that there are no standards for this, so it's not like the insurance company is going to say, well, you used the flashlight and you should have used the bat. There are no standards along those lines. Here's a patient using the bat, and what this thing does, it's got a knob up here that turns it on and off, and it's actually shining a light into the patient's eye as the patient's looking through this hole here and trying to read the eye chart. And I usually use it on medium. And if the patient drops down to anywhere between 20/50 to 20/60 or worse, that's probably indicative that they're having some issues out in the real world. Let's talk about some other documentation of visual function. Well, there's contrast sensitivity, but again, we don't have any standards by which to compare things, so that's not often done. It's also relatively difficult to do. Visual field testing is obviously something we do all the time and is primarily used in those patients for whom you're concerned that the visual acuity doesn't really match up with the density of the lens that you're looking at. So you look at the lens, you go, well, that's not terribly impressive, and they're seeing 2100. That's a patient for whom you probably want to do a visual field to make sure they don't have some neurologic issue preoperatively, which can then obviously have a major impact on the outcomes if you actually do cataract surgery. So my threshold for doing a visual field test is pretty low. Other things, they're called macular function tests. One is the potential acuity meter, and I'll show you that in a second. The other is a laser interferometer, and that sort of shines a grid onto the patient's retina, and they sort of tell you which way the grid is sort of oriented. The problem with both of these is that they're not foolproof, and the ultimate vision may be better or worse than predicted. My experience with the PAM is that, if anything, it tends to be a difficult test to do, and they oftentimes end up doing better post-operatively than you've predicted based on the PAM. This is the PAM. It sits on you hook it onto the slit lamp and you plug it in. And what happens is, right in this area, it's sending a very thin beam of light that you focus on the back of the lens, and it's actually projecting an eye chart onto the patient's retina. And you ask the patient to read. The problem with this story is that as the patient reads, they tend to move their head as they're talking, and then they lose the image. So you sort of have to tell them to memorize a couple of letters on the smallest line and then kind of go from there. It's not a particularly easy test to do, and when you have the patient with Parkinson's who's got their chin moving around, they're probably not going to be able to do it. Let's talk about objective lenticular evaluation. We do it by the slit lamp, but there can be other clues as well. If you're retinoscoping a patient, or alternatively looking, because you're in a consult situation, using a direct ophthalmoscope, if you put it on +10, you can see what's called the nuclear sclerotic button or oil droplet. And this is a slit lamp picture, but it sort of demonstrates what I'm talking about here. And you can see this sort of ring right here. And what this represents is an area where this part of the nucleus has a different density or index of refraction than the peripheral portion. The reason this is important to know is that when you see this, you have to make a notation, at least mentally, that when you're doing the phaco, that once you get to here, it may have taken a fair amount of energy, but once you get out to here, it's really soft, and you can continue to blow through and go through the capsule. So this sort of modifies your technique a little bit. We do a full eye exam. We start out looking at an external examination. Does the patient have blepharitis or ptosis? I'll show you these in a second. Does the patient have really deep set eyes? If they do, and you're trying to do cataract surgery superiorly, what's going to happen is you're going to end up in a situation where you've torted the eye inferiorly, and now you lose your red reflex, and that makes the surgery dramatically more difficult. So if you have someone with really deep-set eyes, it's probably not a good idea to operate superiorly, and you'd rather do that temporally. If they have shallow orbits, the problem there is that the globe can sort of start to prolapse through the lid speculum, and that can cause a positive pressure situation. So those are patients you don't want to crank the lid speculum too far open to try and minimize that. Here's a patient with significant blepharitis. You want to get that cleared up to minimize the risk of an endophthalmitis. And obviously, if they have ptosis, you want to document that so the patient can't come back later and say, oh, I had perfect eyelid position beforehand, and now look at me. You do a slit lamp examination looking at the cornea. Do they have corneal guttata? If they do, that means they have an increased risk of potentially having their cornea swell either acutely in the immediate postoperative period or long term. Do they have other problems like peripheral thinning, keratoconus, or corneal scars? All of those are indications to do corneal topography. As it turns out, upstairs they tend to do corneal topography on pretty much everybody that's getting signed up for cataract surgery. You want to check the anterior chamber. What's the depth? Is it really shallow, in which case you may have trouble getting your instruments into the eye, or is it really deep, in which case you're going to be working down in a hole, which makes things technically more difficult. Is there any evidence of inflammation? If there is, you want to be controlling that, and the current feeling is you'd like to have them relatively inflammation-free for a period of 3 months before you actually do the surgery. Sometimes you can't do that. You want to document their dilated pupil size, because that's going to have an impact on what you're going to do in the operating room, and I'll show you that in a second. Here you can see a patient with Terriens, marginal degeneration, and obviously this is a case you don't want to do, make your incision superiorly. But in addition to that, the other consideration is this area is probably very thin and prone to perforating if you have long-term meaning 3 weeks worth of steroids going on. So this is somebody you're going to want to modify your steroid usage in. And in fact, these are oftentimes cases where you may put them on systemic steroids to try and avoid the topical steroids.
In practice, what do you do with these patients?
I would have cornea look at them beforehand and sort of guide that, just because it's, I have to tell you, I've seen one of these in my career, so it's rare enough, and having to explain to the patient that they've actually perfed postoperatively is a big enough issue that you'd like to make sure that they've seen someone preoperatively. The other reason to do preoperative referrals is that not because it's necessarily going to change what you're going to do, but it sort of reinforces the concept that they have a problem. So 6 months afterwards, when they're having an issue, and they say, well, you never told me about that, and you say, remember I sent you off to that specialist? Why do you think I did that? It then becomes, again, that's the expectations category. And it's amazing how short the patient's memory is when it comes to things like this. Okay, on the slit lamp examination, when we look at the lens, we usually grade it, the cortical, nuclear, and PSC changes separately. They're graded on a 0 to 4 scale. We use the angled slit beam and transillumination. We look for presence of nuclear sclerotic clefts or vacuoles, as we showed you before. You also want to document if the patient has exfoliation syndrome. Why is that important? Well, 3 problems. One is that those patients tend not to dilate well. The second problem is they tend to have an issue with postoperative pressure spikes because they have lousy outflows. So you probably want to be putting them on some medication to prevent that. And the third and biggest issue is they tend to have weak zonules, which can lead to surgical excitement in the operating room. So you want to look for what's called phacodenesis, and that is the lens moving around at the slit lamp, because if it's moving around at the slit lamp, it's going to make the surgery worlds more complicated. And the way I look for a phacodenesis is I have them look straight ahead at the slit lamp, and then I just take my finger and sort of tap on the eye to see if you can see the lens moving. The other way to do it is to have them look left and right, but typically whenever they come back to the central point, it's not where the slit beam is. So that tends to be a little bit more frustrating to do. But if you just actually push on the eye gently, you'll see the lens move if there is phacodenesis. And again, that changes your preoperative discussion. Here's a patient with exfoliation syndrome. You can see the amyloid, we think, deposition on the surface of the lens. It tends to be in a ring-like fashion because this area in here gets rubbed off by the iris, through normal iris movement. But again, these patients can have problems with elevated pressures and weak zonules. Here's a patient with essentially a congenital absence of their zonules in this area. Why do I say congenital? Well, you can see it's scalloped. If this were acquired through trauma, this would be nice and smooth. But in any event, this patient's at increased risk when you go to the OR. There's an excellent chance you will end up having vitreous prolapse through here. The other problem is, in order to do this case, you'd have to use a capsular tension ring to try and re-expand this area, and you may have troubles with orienting and centering an implant. So these can be obviously challenging cases. Here's another one. Dr. Diener, what do you see here?
Posterior polar.
Okay, that's right. And the way you know this is a posterior polar cataract rather than a typical PSC is it looks like an onion that's been chopped in half and you get these rings. The significance of this is that this represents a weakness in the posterior capsule. And the problem with that story is that it means that you have to dramatically modify your technique. You do not want to do hydrodissection because you can blow this area out, and now you have an open capsule and the entire lens in the eye from the jump, and that's going to potentially cause all sorts of trouble and probably a retina consult in there. So it dramatically changes how we approach these things. And it also means that the discussion preoperatively needs to be, this is one that potentially could require our retina colleagues to come in and do some additional work. And the patient needs to be aware of that. Okay, let's talk about looking at the retina. Well, when we look at the retina, we obviously do it using, if the posterior pole is visible, using an indirect, and we also do slit lamp biomicroscopy with a 60, 70, or 78 or a 90 diopter lens. And depending on what we see, we may get an OCT. That leads us to another issue, and that is there's a discussion right now as to whether or not every cataract patient should have an OCT prior to cataract surgery. That debate is ongoing, and it's not clear. I mean, it's not an trivial test to do, and it's somewhat expensive, and it's not clear that everybody needs it. However, there are times when knowing what it tells you would dramatically influence your preoperative discussion. So that's sort of an ongoing area of debate. Sometimes we do fluoresceins, although I will tell you the number of fluoresceins that are done anymore is few and far between. That's where you inject dye into the eye, and this dye circulates through the retinal vasculature and then through the choroid and gives you information. I feel like I'm explaining what an LP record is. Anyway, it's something that was done. It was something that was done probably 10,000 times a year here at Wills back in the 80s, but now is almost never done. If the posterior pole is not visible, the answer is we get a B scan. You want to rule out a detachment, a tumor, and the folks upstairs are actually very good at being able to give you a hint as to whether or not somebody has some macular degeneration, because they can look at sort of some changes in the fovea. And here's a patient with what you look at and say, well, this looks like a pretty normal B scan. There was some concern about some hyperreflectivity in here that could represent a scar. So again, that changes your discussion. Here's a patient who has a significant background or non-proliferative diabetic retinopathy. This obviously needs to be treated before you get to the operating room, and presumably we'd be sending us off to the retina docs where they'd be giving injections of something, either anti-VEGF or steroids, and probably supplementing it with a focal laser. And here's a patient with a Foster-Fuchs spot in high myopia, and this patient has a retina that's probably not compatible with excellent postoperative vision. So again, you need to modify the preoperative discussion. Here's a patient with an OCT, and we can see that there's an epiretinal membrane here. This one doesn't look too bad. This is probably one of those cases that if you found this and you send it off to the retina docs would say, go ahead and do the cataract. If there's a problem postoperatively, we'll deal with it then. Sometimes if the epiretinal membrane is bad enough, then the retina folks will say, we'll do it as a combined case. So you'll do the cataract first, and then we'll go in and peel the membrane off. Here's a patient with obviously significant macular edema that needs to be cleared up preoperatively by the retina docs. If you go ahead and do cataract surgery with the retina looking like this, it's only going to be made worse postoperatively. Other patient considerations. Well, you want to look at the physical characteristics of the patient. Is the patient obese with a bull neck? If so, they're likely to have positive pressure issues. Do they have respiratory difficulties or scoliosis and ankylosing spondylitis? If so, positioning the patient is going to be potentially challenging. You want to do sort of a mini anesthesia evaluation. Are they a grade 4 anesthesia risk? What's that mean? Well, do they have poor cardiac function with a lousy ejection fraction? And are they on supplemental oxygen? In both of those cases, they can't be done in a freestanding surgery center, and although we down on the 7th floor are a full hospital, they're not real excited about doing people with ejection fractions of 20%. So those are the kinds of things that you need to have a discussion with anesthesia before you take them to the operating room and have them canceled. Do they have...
What are you doing with those people in private practice outside of, I mean, even here we have some difficulty getting them in. What are you doing with them out in the community?
You mean if they're bad enough? A lot of times the cardiologists say, no, the patient is not a candidate for cataract surgery, and that makes it easy. It's unfortunate, but you know, although we don't think the procedure is very involved, you really don't want to have the patient having a bad outcome systemically. So you know, we sort of have to you know, we sort of have to take the lead from the cardiologist. And I've had patients that I've sent to pulmonary people, and the pulmonary docs say, no, this patient's just not, you know, their respiratory status is not adequate to allow them to do any kind of surgical procedure. So that happens. Is the patient developmentally delayed? Do they have extreme anxiety, or do they only speak a foreign language? In all those cases, they're not good candidates for topical, and you probably want to be doing the case under general. And when it, excuse me, when it comes to anticoagulants, we used to try and stop these, but now the feeling is the risk of stopping them is greater than the risk of having a problem in the operating room, and so we leave them on their normal anticoagulation. Let's talk about the floppy iris syndrome. This is a syndrome that was described by David Chang probably about 10 years ago, and he was able to figure out that Flomax was the main culprit in these patients who have this. And the problem is now that it's rare for patients to come in and say they're on Flomax, because Flomax is the brand name and everybody's on a generic which is called tamsulosin. The problem with that is most patients can't pronounce that name, and so if the patients can't pronounce it, they're not as likely to tell you that when they're giving you their list of medications, which is a major issue. The other problem is that there's a medication out there called Jalin. It's not all that common, but it's actually a combination of Avodart and Flomax. So if you just say, well, they're on Jalin, you may think, no, they're not on Flomax, but in fact they are. What does this do? Well, it causes a permanent change in the iris. And why does this happen? Well, there are receptors in the iris that are the same receptors, as it turns out, that are in the prostate. The problem with this story is that you can't predict how many of these receptors, that are alpha receptors, are in the iris and how many of them are in the prostate. So you can have a situation where the patient gets put on the medication for 3 weeks for their prostate. It doesn't work because they didn't have very many receptors in their prostate, but they have a lot of them in their eye, and they don't remember that they were put on it, and now 6 years later you're doing cataract surgery and their eyes flopping around. So the answer is this is an inexact science. The converse of that is also true. The patients have been on Flomax for 20 years. They dilate great. You get up in the OR and their iris is like they've never seen Flomax. So you really can't predict it. The exposure time before the change occurs is unknown, but my feeling is it's probably as short as a week or two, and which is long enough for them to have had a trial to find out if it works from a urologic standpoint, and promptly then forget about the fact they were ever on it. It's used in both men and women. Obviously, the women don't have prostates, but the reason it gets used in women is because of the fact that sometimes women will get stones in their ureters, and the urologists are trying to relax the smooth muscle to get the stone to pass. What does it do? Well, it causes an intraoperative atonic iris, and it also leads to progressive meiosis during the surgery. And I'll show you a video in a second. What do you do for it? Well, there's sugarcane, which we use on every case, and my feeling is it doesn't work very well in these folks. Helon 5 does work, but they still can have things flopping around. And the other thing you should know about this is it depends on how long the case goes. So if you're doing the case in 7 minutes, you're likely to be able to get out of there without a problem. If you're doing the case in an hour, you're almost certainly going to have an issue. So what are the real definitive ways to deal with this? Well, one is called iris retractors, and the other is called a Mayugin ring. These are the pictures of them out of the box, and here they are in the patient. And these have little loops in here that you hook onto the iris, and this hook actually gets hooked onto the iris, and the silicone sleeve gets slid down so that, and there's friction there so that it actually stays in position. And in both of these cases, you get adequate visualization, but more importantly is it prevents the iris from moving. And here's a video. This is from Dr. Tyson, one of the members of our staff. And you want to watch the edge of the iris and see what happens as flow is being directed throughout the anterior chamber, and especially when it's directed at the iris. You can see it's sort of dancing around here and flopping around like a sheet flapping in the breeze. Two problems with this. One is that as the case goes on, the iris gets smaller and smaller, so by the end of this you can end up with like a 2.5 millimeter pupil or smaller. And the other problem with this is that the studies that have been done show that there's a dramatically increased risk of developing capsular tears and vitreous loss in these patients. So the prudent thing to do is to actually go and put in either a hook or a ring. So what do we do? What do I do? Well, if somebody dilates poorly, I'm going to do a ring or a hook from the beginning of the case. If the patient doesn't or dilates well, then the question is this going to be a problem during the case? And it's not a problem doing the rhexis, but it's going to be a problem as the case goes on. Watch this as he pulls it out. Because the iris has no tone, it comes flopping right out. Yes?
You make your wounds more anteriorly in these cases?
I usually don't, because I don't think that's necessarily a big advantage. I don't think it's really going to alter the ultimate outcome. Meaning to say that's like using sugar cane. I just don't think it does enough to be anything that's a game changer. But what I was saying is, if the patient dilates well, what I will tend to do is to, at the beginning of the case, make my paracentesis and take some BSS and squirt it directly at the iris. If the iris stays stable, I'm okay. If the iris starts to quiver, then I'll put in a ring or some hooks.
What about Dr. Lehman? Obviously, it's best if you could put the Mayugin or the iris hooks in early on in the case. What if you're at that point in the case, the lens is in the iris plane, you're trying to get it out? Can you put in a
Yes.
Mayugin after you get
Well,
it out?
I wouldn't put in a Mayugin ring in. I think that's probably a little more difficult. I would put in hooks at that point because I think you have a little more negotiating room. The only problem or the thing that you have to be careful about is when you're putting a hook in that patient, you have to be careful you don't grab the anterior capsule. So that's really sort of your biggest concern as you're doing that. But if you put the hook in by turning it sort of sideways just to kind of get under it and then slide it into position, you're actually not diving very deep, and so you're unlikely to grab the anterior capsule. But as you're pulling on it, you want to be making sure that you don't have the anterior capsule in your hook at that point. Let's talk about eye medications. Well, preoperatively, we typically use antibiotics for 3 days beforehand. That's the standard of care, although there is no data to suggest it does anything. It's still the standard of care. I usually use a 4th-generation fluoroquinolone, either Vigamox or Gatafloxacin, which is Zymaxid. I will use Polytrim if the patient's fluoroquinolone allergic, or if the patient has insurance issues where they won't pay for it. If you're doing dropless surgery, the patients obviously don't get any preoperative drops. We'll discuss that in a little bit. Preoperatively, the question of using NSAIDs is a little bit controversial. There's many surgeons who use them on every patient. I tend to use them primarily when the patients have some macular edema, such as diabetes or a vein occlusion, if they have uveitis and epiretinal membrane, which increases your risk of developing macular edema, or if you're going to do a premium IOL. Those are all good cases for NSAIDs. I don't tend to use them in everyone else. Two reasons. One is it's an additional expense, and sometimes it gets really expensive. Sometimes, you put them on their regular drops and they're spending $350 for their drops, which gets a little bit crazy, which also means that a lot of times they won't use them. But the other reason why I don't like to use an NSAID routinely is that I tend to dose my antibiotic every 2 hours after the surgery. We'll talk about that in a second. But the more drops you have in there, the more the potential for confusion in terms of the way the patient use the drops. Dilating drops, we use a cocktail of niacin-ephrin, metronidazole, and cyclogel. I use them, and also a topical NSAID. I use them Q 5 minutes times 4 in the pre-op to get them well dilated. The NSAID helps to prevent the pupil from coming down during the surgery. Again, we tend to use sugarcane in almost all these cases, so even if they're not that well dilated, the sugarcane will oftentimes help. If it doesn't, then you go to hooks or a ring. If you're going to be doing this under topical, you use either lidocaine gel or Tetravisc drops. Some surgical pearls. You want to be familiar with the equipment and the machine settings. I tape everyone's head to the stretcher. Why is that? Well, sometimes people get a little confused. Remember, we're dealing with an older population and you've given a whole bunch of anesthesia, so they may think they're in their living room and they want to get up and, find the remote so they can change the channel on their TV set. Well, the problem is when they get up in the middle of the case and you have instruments in the eye, that can lead to a bad outcome. So the advantage of having their head taped means you get an extra couple of seconds to get stuff out of the eye before they actually make a dramatic movement. You want to confirm that the implant is correct for that patient in that eye. You want to review the chart for some documented special considerations. Are you going to use a special incision site because of the astigmatism? Do they dilate poorly, have exfoliation syndrome, Flomax, a white cataract, etc.? The ideal case for phaco emulsification is a young patient, which means their lens is not going to be that hard. They have a PSC cataract, which means they're going to see well afterwards. They're going to notice a dramatic difference. They have a calm, accepting personality and relatively shallow orbits. The postoperative care begins at the conclusion of the case. You tell the patient the operation's over, everything's gone well. You thank the patient and the OR staff. Instructions for the day of surgery. You want to encourage the patient to be up and about. I've never heard of a DVT associated with cataract surgery, but who knows, there's probably a case report out there somewhere. Patch usage. I don't tend to use a patch. I do use a shield at all times unless they have their glasses on. And some of the residents will leave the patch and a shield on until the next day. I have them remove it after about 6 hours and then start the drops. Analgesics, typically Tylenol or Motrin. If they need something more than that, I'm worried that their pressure could be elevated, and that's the cause of their pain. So before I actually start pulling out the narcotics, I usually will treat them empirically with Diamox and see if that gets it better, because usually that's the problem. Now, if you've done something silly like abrade their entire cornea during the case, and you know that, then that may be the source of their pain. In terms of drops, I use Pred Forte, and if I'm using an NSAID 4 times a day, Zymaxid, Vigamox, or the Polytrim every 2 hours, and none if you're doing dropless surgery. And let me tell you a little bit about dropless surgery. The way this is done is at the end of the case, you stick a cannula through the zonules and you inject Trimoxy Vanco. And that the tri is triamcinolone, the moxy is moxifloxacin, so that's the antibiotic, and Vanco is also the antibiotic. And you inject this through the zonules into the vitreous. Now, problem with Vanco. Although there hasn't been a case of this with the Trimoxy-Vanco, surgeons that were injecting vancomycin into the eye have had episodes of a thing called HORV. What's that? It stands for hemorrhagic occlusive retinal vasculitis, and it is devastating. And it's associated with the use of using vancomycin intraoperatively at the end of the case. These patients frequently end up light perception or worse. So it's a devastating thing to occur, and so it has sort of rained on the parade of using intraocular vancomycin, which used to be something that was reasonably common. It hasn't been reported in the Trimoxy-Vanco folks. We think because of the triamcinolone, that tends to reduce the inflammatory component that would be sort of the kickoff point for the development of that. But again, most of the folks that are doing dropless have dropped the Vanco. Diamox or other carbonic anhydrase inhibitors, I use them especially if they have exfoliation syndrome, a history of glaucoma, or if you've had to do an anterior vitrectomy. I encourage the patient to spend the evening with someone. You want to give the patient a printed sheet at the end of discharge from the surgery center. You want to tell them to use eye protection at all times. I tell them to use the shield in the shower. What happens when you get soap in your eye? What do? So I tell them I don't care about the soap in the eye. I care about the fist that comes afterwards. Drop usage, as we just discussed. Activity, I tell them they can do pretty much everything, except I don't want them doing anything, lifting anything heavy enough to strain. So I tell them to wait 6 weeks before they move their furniture. In terms of the rest of things, you don't want to tell them what's normal, and if something's abnormal, they have their number to get a hold of you. Post-op day 1, we're looking at the vision and pinhole, the slit lamp. Are they Seidel positive or negative at their incision site? What's their corneal status look like? What's their anterior chamber depth and reaction? What's their implant position, and what's their pupil look like? You also want to check their pressure. That's probably the most important thing. Some people are doing post-operative day 1 at 6 or 8 hours after the surgery. That is something that is now sort of talked about. It's not commonly done, but some folks are doing that. I will do a fundus exam if it's indicated. So if the front part of the eye looks perfect and they're seeing 2200, that's when I will start looking around, checking their refraction. Do we have the wrong implant, or is there something that's going on in their retina? And here's a patient with the Seidel positive. How does this happen? Well, you take fluorescein and paint it on the incision, and if the aqueous is leaking through, it dilutes the fluorescein and you get this pattern. Here's another one-day post-op patient where you can see the pupil still dilated. The implant is in the bag. You can see here's the rexus, and you can see the lousy corneal light reflex because that's the temporal area where I hydrated the incision at the end of the case, and so there's typically some fluid in the cornea giving it a lousy light reflex. So this is essentially what it's supposed to look like one day afterwards. Okay, what to expect? Well, you can have some lid edema or ptosis, all that's normal. You can have a subconj hemorrhage, usually that's surgeon-induced, and I've been there many times. When you're holding with a forceps, you sometimes tear a little blood vessel. You have to reassure the patient it doesn't mean anything. Chemosis is oftentimes because you went and entered too far posteriorly and before the insertion of tenons, and that will lead to chemosis during the surgery, which is a big pain in the neck, and the patient can have some of that the next day as well. The cornea, you want to look for either stromal or microcystic edema, and do they have any Decimase fold? Microcystic edema is frequently a tip that your pressure's high. If they have stromal or Decimase folds, that can be either because they had some gutata preoperatively, or it could be because you spent too much time with too much fluid going through the eye, or you were phacoing too close to the cornea. Anterior chamber, you want to look and see how much of a reaction they have, and if they have a hyphema. Hyphemas are uncommon, typically noticed when people do scleral tunnels and enter too far posteriorly, sort of unroofing the ciliary body. That can lead to bleeding. Post-operative visits, I see them at day 1 and 5 weeks. Day 4, I sort of have become variable with. In fact, don't do it all that often. If the patient is seeing well at day 1, what are we looking for at day 4? We're looking for an endophthalmitis. But if they're going to have the start of an endophthalmitis and they're seeing well at day 1, they're going to notice their vision gets worse. So I tell the patients, if your vision starts to get worse, I need to hear from you and we need to see you. So that kind of takes out the day 4 visit. And I see them at 5 weeks. Again, we're doing the vision, slit lamp exam, and checking their pressure. I refract them at 5 weeks and sooner if there's some question. Keratometry I don't always do at 5 weeks. And the fundus exam I often do at 5 weeks, but not always, because I'm going to see them back about 3 or 4 months later. But even if I don't do a fundus exam at 5 weeks, I tell everyone what the symptoms of a retinal detachment are, and if they notice any of that, they need to call you right away. Let's talk about some basic incision concepts. And we'll sort of run through this quickly. The keratometric effect of a partial or full thickness corneal, limbal, or scleral incision is an eventual flattening of the surgical meridian. What's that mean? Well, it essentially means wherever you put a cut in the eye, it's going to flatten that axis. Okay, that's pretty easy. Transverse or arcuate incisions placed close to the corneal apex induce greater meridional flattening than do more peripheral incisions. What's that mean? Well, if you put the incision millimeter into clear cornea, you're going to have much more of an astigmatic effect than you have at 2 millimeters on the sclera. Okay, some ground rules. With the rule, astigmatism means the patient's cornea is steeper vertically or they have plus cylinder vertically. Against the rule means they're plus at 180 or horizontally. And when we talk about closing an incision, if we're assuming it's a superior incision, a vertically placed suture will induce with the rule astigmatism. So it means it steepens the vertical axis. That is transient and will decay with time and or cutting of sutures. So with the rule astigmatism that they have immediately after the surgery will degrade over time. Okay, if you cut sutures, it'll degrade much more quickly. A deeply placed suture limits the internal with the rule astigmatic change and creates a physically stable wound. Well, this is like when you do corneal lacerations. The goal is to have your suture placement relatively narrow, meaning you don't want to take a big bite, and you want it to be at 90%. And that's true when you do a corneal laceration as well. Why do you want to have the suture go down to 90%? Well, if you go down to 50%, you get what's called a lambda defect. So the cornea looks like this. Here's the part that's sutured, and then the bottom is sort of out like this, and that means it's not stable. So you only have half the cornea sort of supporting that area. More likely to rupture, but more importantly, more likely to develop against the rule drift. Okay? And it's essential to establish physiologic levels of intraocular pressure prior to suture tension adjustment. So if you think all those sutures look perfectly tensioned, but their pressure is 0, and then you crank their pressure up to 20, all the sutures are going to be really tight. So you want to have the intraocular pressure normal when you're trying to adjust the sutures. With the rule, astigmatism decays in the direction of against the rule, most significantly over the first 12 weeks after surgery, but the refraction does not stabilize for a year or more after the surgery. So this has significance. If you've done an extra cap and you have some sutures in, you have to be concerned that whatever your refraction is at 6 weeks is not what the refraction is going to be at a year. Okay, and if you've left them with the rule of astigmatism, that's not a big deal because it's going to drift towards against the rule over the ensuing year. If you have them so that they have no astigmatism at 5 or 6 weeks, you can be pretty sure they're going to have a lot of against the rule astigmatism at a year. That's just the way things drift. Fine elastic suture material, such as nylon, causes less against the rule drift than thin inelastic suture, which is silk. We don't use a lot of silk, but I'll show you for demonstration purposes in a second. Factors that increase wound compression and with the rule cylinder. An anterior bite. So if you go way towards the cornea with your bite, it's going to cause more compression of the tissue and therefore create more with the rule astigmatism. Again, sort of the same deal with a wide bite. A deep bite is going to increase your with the rule astigmatism, but we want that because that creates a more stable wound. Obviously, if you tie your sutures tightly, or you have a greater number of sutures, you're going to have more with the rule astigmatism. And if you overlap the wound edges, what's that mean? Well, if you take your cornea and you actually have it so that it overlaps a little bit of the sclera, that's going to create more with the rule astigmatism. Wound gape and the against the rule cylinder is favored by the opposite of these factors. And let's take a look here at an old cataract patient. And you can see these little divots here. This is what happens when you had a patient who had silk sutures. Why is silk not a good suture material? Well, the problem is in the first 2 days or 3 days after cataract surgery, the cornea swells. And the problem or the advantage of nylon is that as it swells, the nylon maintains its elastic strength, and then when the swelling goes away, you still have the same elastic strength going on to support the incision. The problem with silk is that it's inelastic, and what happens is as the cornea swells, it cheese wires through the tissue, and then by the time the corneal swelling's gone, all of the sutures are loose. And what that leads to is what's called an underlapping of the cornea. And so you can see this little gap here. This area of the cornea is supposed to be right up here, but it's not. It's underlapped, and that essentially leads to against the rule astigmatism. Let's talk lastly about cutting sutures. A tight suture will steepen the corneal curvature in the meridian of the tight suture. Well, what's that mean? Well, wherever your suture's too tight, you're going to have a lot of plus cylinder, and that's the suture you're going to want to cut to reduce that. But you have to evaluate the preoperative Ks before you go cutting any sutures. And this is something that's frequently not done. So the patient comes in, you look at them at 6 weeks, they've got a tight suture at 12 o'clock. So you go, well, it's tight, and look, it's a lot of with the rule cylinder, so I'll just cut it. Well, that's a bad thing to do until you've checked their pre-op Ks, because if they have 3 diopters of against the rule before the surgery, you're going to end up making that 3 diopters worse by cutting that suture. So you want to leave them with a lot of with the rule cylinder, because they're going to degrade in the direction of wherever they were preoperatively. Do you follow that? Okay. So the goal is you want to hesitate cutting if the pre-op Ks are against the rule. What to cut? Well, you want to cut the suture in the axis of the correcting plus cylinder. And you want to avoid cutting adjacent sutures on the same day. You can end up with dramatic results if you do that. And you can't undo the cut. When to cut? In general, you want to wait at least 6 weeks and have them off steroids for a week. But some of this depends on the rate of wound healing. And the rate of wound healing is affected by the age of the patient. So old people don't heal the wound as quickly. And also the amount of steroids. If for some reason you had them on the prednisone drops 6 times a day for 4 weeks, and now you've just tapered them off, their wound healing isn't going to be the same as somebody else. Some tips on what to, in terms of figuring out which is your tight suture. Very often you will see tension lines in the corneal stroma. You also can find an indentation of the epithelium. And what that does, it gives you a little fluorescein triangle on the corneal side of the suture. Let me show you. Here's a tight suture, and you can see the stria, or the tension lines, going in that direction. If you put fluorescein on here, you'd find a little triangle with the apex pointing towards the tight suture. How do we do this? Well, the technique is it's done under topical anesthesia like opthetic or tetracaine, and you use a super blade or a fractured razor blade. You cut the suture close to the corneal entry, and if you do that, the suture ends will retract. Let's go back here. Sorry. If you cut right here, what's going to happen is this area of the suture is going to stick up in the air, and the patient's going to feel it every time they blink. So you want to cut right here, right at the edge where the suture dives into the cornea. And if you cut it there, what happens is it retracts in both directions, but there's no end sticking up when you're done. Okay, I only remove a suture if it's loose, and that never happens the day that you've cut it. They can become loose days to weeks to months or years later. But if they're loose, two things have happened. One is it's bothering the patient, but the second is that it's eroded through the conjunctiva, which means it's sitting right there for you to easily grab and pull out. If you're trying to pull the suture out and it's underneath the conjunctiva, it's a lot more rooting around. And then after I remove a suture, I will Sidel the patient, make sure they're Sidel negative. If they're positive, I will put them on antibiotics. Very good. Anyone have any questions? I hope this was of some use. Very good. Well, thank you very much for your attention.
Just because they were like strangers.
Yeah. We love my mom. Here. What's wrong with that question? At least we're like
Do I need to sign anything?
I don't think so.
So I switched it.
Thank you.
Yeah, I switched it. Sorry, I'm actually on the. Sorry.
They were avocado.
Have a good one. Sorry.
Nope. Okay.
It's mountain.
It was a Sunday morning. I forgot.
She's actually
Yeah.
So they're probably
Okay.
Yeah, no problem.
I did.
You're not wrong if you do.
I did.
Like, if you like, if they're rubbing, yeah, or but calling them, yeah, like, it's totally fine too, but I personally do not, just because, yeah, I personally wait till then, because, I'm better as the more farther along, they're better, it doesn't change anything, Brett presented a case, I went for a chief shot last year, the wedding was like this posterior hard case that he and I saw, and it was the only case that I've ever seen where the exam changed 4 hours later. And even then, it was minimal change, and did not affect outcome.
I thought it was not here.
You know, even if it's arm, I wouldn't call him and tell him. I would call him right away if it's.
Where was it?
My usual thing is if it's midnight or before, I call them right away to see if they want, because even if they're asleep, they're not like, they're not waking up at 2 a.m. Or I wait till like 5 or 6. And when I'm calling them, it's like, I've got, I always order, and I always order Ori, especially when you're on a Jeff call, and you've got an endogenous.
Yeah.
Sometimes you'll get these transfers more often on Jeff call that are endogenous from another hospital, and I get there at 2 a.m. and I think it's still okay. If you get the call late to go see that patient at 4:30 or 5 in the morning, and call right.
I did that.
I mean, it's usually a medicine intern who's on overnight, and they're just calling you. Like, they're not like sitting there going, oh my gosh. They just got it. They're finishing up their HP. They've called on the consults. Like, nobody's sitting there waiting for you immediately.
Right.
And then I go in and see them and I order bank set test and Ori.
Right. That's what I did for the endogenous.
Yeah. If I'm delaying to call them, I especially make sure that I cover all the bases, because you feel so stupid if you
Alright, that makes me feel better, because both times I waited and I was like,
It should be.
I'm
No.
like hurting this person.
You're not. There, I've seen one where the exam sort of changed
Yeah,
it
where I was
should
in
be
it did
like,
not
in
fit
2 weeks, I
anything.
have like,
Like it was a,
little call.
we didn't know
Sort of like-
if it was ARN or not, and it was like 2 a.m. They came in when I was like the first year, and I called Brett down, and he looked at it and they were like,
I'm unconfident.
what are we looking at here? It was odd. It didn't really totally look like ARN, and then we waited till 5:30 or 6 in the morning until the cat came in, and it looked like the AC reaction was a little worse, but
Yeah.
it will, there's no way that you're causing it.
Okay, that makes me feel better.
What was your research one on Jordo about?
Oh, it was like, this, like, you know how it is when, like, you have people with, like, neuro-op stuff. It was like a binocular diplopia, and I tried to map him out in triage, and he just, like,
made it a little more exciting. But anyway,
he, like,
so
wouldn't
what
fixate
ended
on
up
me
happening
to,
is
like,
I
actually
did
map him by, like, looking at his
Mhm.
movements. And so I tried to just do it subjectively with the head turns, and he came with a right hyper, and he was, at baseline, he was sitting with a left head tilt. So I was like, oh, it's gonna be a fourth.
Yeah.
He's like compensating. And then I tried mapping him out subjectively, and at first it did, and I went to confirm it, and then he gave me the exact opposite answers. And I turned his head back to the left, and I said, oh, that's way worse. I was like, what? Maybe he has a skew, but then he had left-sided ptosis too, with like pupils that were pretty much the same size and full motility. And then you're like, that's super busy, and then like when I'm about to like go take him to like do his full exam again, they're like wheeling him down. And I like just put in an MRI, so I like really quickly put in an MRA just in case.
Yeah.
And then they called this like the left pica or left PCOM had a condylum, which I'd never heard of before. I was like, do you know anything about that?
Yeah.
And it was like late, so I guess I just wasn't sure where it goes with neurosurgery. We call them like, I don't know if I'm doing consult, I just don't know what this is.
You know, I
wasn't
what
sure. I
happened?
was like,
I heard what Jordan said to you. What happened? What
When I came in their consult, it was, I feel like I've seen this guy before, I can't remember his name, but he was
billing for a complex.
Good morning.
Well, good morning.
How's your vacation?
You know,